Hello, friends. Today is the first of a number of calls that I will be making to family, friends, and colleagues in several places of the world. Today, I'm honored to have my cousin, Dr. Thomas Ruiz, who is an OBGYN doctor in California and has agreed to kindly be the pilot of this experiment. So thank you, Tommy, for being on the call. Could you tell us a little bit about the situation in California right now?
Right now, we're actually doing quite well in California because we socially isolated early. We have been in a state mandated stay at home situation since March the 19th. So we are expected to hit our peak on April the 17th, and our curve has definitely flattened. So to this point, we have not overwhelmed our hospital system. It has created certain challenges taking care of our pregnant patients, which I'm sure we will discuss in a moment.
Yes. So first of all, I want to thank you on behalf of all your patients and on behalf of everyone, because you are in the front lines. You are there living it in and out, and I really want to thank you. How has COVID affected your practice?
It has, the effect has been tremendous. I work in a fairly large practice, um, in a good size office that takes care of both primary care patients as well as obstetrics and gynecology patients. So there has, so what our group has done, we've been very proactive. Um, First of all, we have been doing a lot of telemedicine visits using the Zoom app. Now, you cannot do that with obstetrics patients in antepartum care because one of the things you need to do with antepartum care is with each visit, you need to measure the uterine fundus, make sure it's growing properly, get a fetal heart rate, check a blood pressure, and check a urine for protein. So, unfortunately, we can't do virtual visits for the antepartum patient population, but by having done the majority of the other patient visits via virtual visits, we've created a little bit more of a safe environment for our pregnant patients to come up to the office. Now, the other thing that's made it hard on our patients is a typical obstetrics patient comes in with their husband. Because of the COVID-19, there are no visitors allowed in the office. Only the patient is allowed to come upstairs. And before coming into the waiting area, the office setting, they're pre-screened. They're asked if they have any signs and symptoms of COVID-19, cough, GI symptoms, fever. If the questionnaire is negative, they are then, a temperature is then taken, and then they are allowed to go upstairs to have their office visit. And that is, and the labor process has become quite stressful. I'm sure people have seen it in the media. But in terms of the outpatient setting, it's become a little bit more of a lonely visit for the patient because in Southern California, parents, the spouse or partner, they really want to be involved in the prenatal care. So we have a lot of the visits when I'm doing measurements and listening to the fetal heart rate. I'm allowing the patients to turn on their cell phone and their FaceTime app or whichever, if they have Android, whichever equivalent, so that at least the partner can have some involvement and feel like they're there.
And how has social distance affected the operating room and the labor room? How has that affected your ability to treat patients in the operating room?
In terms of the operating room, we've basically eliminated all elective surgical procedures. And what most people don't realize, an elective procedure by definition is anything that is pre-scheduled. So it doesn't matter if you have a major problem like a big uterus and heavy bleeding, or if you have severe endometriosis and pelvic pain. If that surgery was scheduled, it was canceled, and we're trying to manage those medically until they open up the operating rooms again. With respect, so the only surgeries I'm doing are truly emergency surgeries, like an ectopic pregnancy or a woman who's bleeding I can't stop and is needing blood transfusions. With respect to labor and delivery, that has also become an interesting challenge. Well, typically you would allow 2 or 3 women and people to visit a woman while she is in the labor process, and we have special things like birthing balls, and we allow them typically to walk the hallways. Now we're in a situation that only one support person is allowed to be with them. When that person enters the hospital with them, they cannot leave. They have to stay with them the whole time. We're not allowed to use any assistance devices with laboring and pushing, like birthing balls or something we call a peanut that helps with positioning. The patients are no longer allowed to walk the hallways. In terms of the delivery room, because we've stopped the use of oxygen in labor rooms because it creates spray. When you get to the second stage of labor and the actual birth process, everyone in the room, including the delivering provider, is in full PPE. Typically, we just have gowns and gloves. We're not masked. We don't usually wear goggles. It's more of a relaxed process. So it is definitely, it's changed the comfort level of the patient. It's become much more difficult.
So let's talk a little bit about pregnancies, and I'm sure questions that women out there have. Can a mother transmit the virus to the unborn baby?
As of now, to date, there is very little evidence of vertical transmission from the mom to the baby. However, there may be a couple of case reports soon to be written up, but those are those are rare cases. And when I say rare, one or two. So the mom can feel comfortable that in utero the baby's safe, so that even if she gets the viral infection, she will likely not pass it on to the unborn fetus.
So I'm going to ask you the opposite question. Can a mother potentially transmit antibodies to that baby that are protective? And I'm sure you heard about a woman today, actually, who I'm sure is not the only one, but who had a baby. The mother was very, very, very ill, and the baby was born coronavirus negative. What are your thoughts on that?
We don't really have enough data to know if that is, to know how often that's going to happen, because we still don't really have a great understanding of the overall virology and antibody response of the mother. In general, with other viral illnesses, when the mother has antibodies to that virus, the baby tends to be protected. And then, as you know, after birth, some of those antibodies pass on through the breast milk to the baby, imparting a certain degree of immunity the first 2 months of life, when a baby is most susceptible to viral infections. So unfortunately, we don't have enough of that. We don't have enough of that information for COVID-19.
And what recommendations do you have specifically for women that are pregnant? What kind of guidance are you giving them?
Generally, we're using the CDC guidelines, which are basically saying prior to 37 weeks, um, practice social distancing, wear a mask when you go out, wear a mask when you go outside, avoid contact with patients who may have been exposed who have active COVID-19. This poses a particular problem to pregnant healthcare workers. And from an HR point of view, we have recommended for pregnant healthcare workers that they be assigned to areas where they are having minimal or not likely to have contact with a sick population. Now, once you get to 37 weeks, we are encouraging more of a self-quarantine approach. Really basically extreme social distancing, because we just don't want you to risk coming in contact with an asymptomatic carrier and then bringing that into the hospital. So 37 weeks is a recommendation. There's a whole list of guidelines put out by the American College of Obstetrics and Gynecology, Maternal Fetal Medicine Division, which actually has charts and gives really detailed outlines on managing this patient population.
Well, I'm sure you're very, very challenged by everything that's going on. I want to thank you for your time, but most of all, I want to thank you for taking it in the chin and going out there and helping women every day. So thank you very much, and I'll talk to you soon.
Okay, thank you, Nancy. Take care.
Take care, Tom.